Good morning. The first topic that is allocated to me is Eagle study. What should we adopt and ignore? Can you forward one slide? Yeah, if you look at the literature, there are 3 publications from the Eagle study. The first one was published, that is the methodology. And this is the most important paper that has given the outcomes of the study. And they also looked at the predictors of long-term IOP control and looked at the possible ways you can predict the outcomes. And if you, as a clinician, if you look at the Eagle study, and the 3 questions that comes to our minds are, does it improve disease control in terms of the angle and angle progression, in terms of the IOP control, in terms of the disc and visual field progression? So with this background in mind, let's look at the study in a little bit so that will help us to understand these questions what we have today. The primary outcomes of the study happens to be quality of life and vision and intraocular pressure control, stability of the disease and safety of the intervention. It was, duration was 3 years after the randomization. And study groups, as you all know, early lens extraction surgery, that is clear lens extraction, compared to the standard care, usually laser iridotomy, followed by a sequence of medical therapy and glaucoma surgery. And the study centers, if you look at it closely, it is one from UK, the rest is mainly from Asia and Australia. And study subjects has to be more than 50 years of age, newly diagnosed PSC with IOP equal to or more than 30 millimeters, or PSCG, that is reproducible glaucomatous visual field defects or disc changes with IOP more than 21 on at least one occasion. And PSC was defined as iridotrabecular contact, either opposition or cynical, for more than 180 degrees on gonioscopy. And what was the difference of the study they were looking at to measure? Those randomized to early lens extraction will have, that was the hypothesis, a higher quality of life questionnaire score, the mean difference of 0.05, lower IOP, again note this, mean difference of 1.75, a 15% lower glaucoma surgery rate. And when they looked at the results, both the quality of the life and IOP control, they found to be better in the clear lens extraction group, which was statistically significant. And they concluded, our results indicate that clear lens extraction should be considered the initial treatment for primary angle closure glaucoma and primary angle closure with increased intraocular pressure. And if you relook at the primary outcomes they have looked at, it's the quality of the life. And if you look at the baseline characteristics between the clear lens extraction and EAC-PA, and the refractive error was little more in the clear lens extraction in comparison to the EAC-PA. Was the difference in refractive error responsible for the improved quality of the life? Once the lens is out, when the patient becomes pseudophakic and possibly quite happy without the hyperopic glasses, was it responsible for it is a question that we should ask ourselves. And the difference of 0.052, what is the relevance of the 5% difference in quality of life? We have to ask ourselves before advising a clear lens extraction for this group of patients. And if you look at the primary outcome, what they have reported in terms of the intraocular pressure, yes, there was a difference of 1.18 millimeters between the clear lens and the standard care. And if you recollect the study hypothesis, they proposed the lower IOP, the mean difference of 1.75 millimeter was what was expected to have a meaningful outcome between the two groups. did not meet the minimum difference they thought would be clinically significant at the beginning of the studies, because they got only a difference of 1.18, it's not 1.78. So the difference is 1 millimeter difference, even 0.75 what we are looking at, it makes a difference. So what about the angle? Because that is very important if you are looking at the progression of the disease either with the PSC or PSCG. And if you look at the gonioscopy data, the definition without indentation, they found 300-degree closure in clear lens, whereas LPA it is 360. Cynical around 90 degrees with the clear lens and 90 equal in the LPA group. What is important to be remembered is missing data. A study which is addressing angle closure outcomes, having this amount of missing data with the gonioscopy is something which is not acceptable, and it is almost cynical closure information is absent in 247. And if you look at the final visit, again there is a significant amount of the missing data even at the 36 months, both with the angle closure and information about the cynical closure. And did clear lens extraction improve disease control? Yes, there is a difference, statistically difference between the two groups, but the difference is not that amount. We don't have any additional information as far as the angle is concerned. Intraocular pressure difference is very minimal. There was no significant difference in change between the groups in terms of the visual fields. As a clinician, I like to look at the complications they have reported with the clear lens extraction. They claim that it is on par with the cataract extraction complication. But is it worth to subject an individual with a clear lens for this, even though it is a small percentage, to expose him to this complication rate, is something we have to question ourselves. And coming to the long-term predictors, which was published much later based upon this 3-year data, among patients with PSC disease, they found that those with the initial clear lens extraction were 10 times more likely to maintain good drop-free intraocular pressure control over 3 years versus LPA. They found Chinese ethnicity, lower preoperative IOP, not using glaucoma drops, and no glaucomatous changes at the baseline factors were associated with the free drop postoperative IOP control. The question I have here is, when so much of angle data on the gonioscopy is not available, we don't know whether the group of subjects who really got benefited were having just a positional closure. With the lens removal, they all got benefited because none of them were on any drops, none of them were having very high intraocular pressure, just the lens extraction has helped. So unless you have sufficient information on the gonioscopy, I'm not sure whether we can claim that the clear lens extraction is going to control the long-term intraocular pressure. The cataract removal, the lens removal per se would have caused the drop in the intraocular pressure. So what is the caution we have to take it in mind? I know it is a big study, so remember removal of clear lens is not equal to cataract removal. All the clear lenses were operated by a glaucoma specialist who are used to doing the surgeries in such a situation. In spite of that, they had complications. One randomized study cannot be extrapolated to the whole of the primary angle closure disease spectrum. PSCG they had was very mild damage. We cannot apply it to the advanced cases till we gather sufficient data offering cataract surgery for significant cataract. If patient is having a significant cataract, offering the cataract extraction is ideal. Please offer laser iridotomy for eyes with clear lens. Did EAGLE study change my clinical practice? Exact in verbatim, it's not. So we have to keep all the possible things what I have discussed and consider doing the laser iridotomy for the clear lens if it is indicated, offer cataract extraction if there is presence of cataract in those eyes. Thank you very much.
Thank you. Are there any questions from the audience? I think we have, because we have one speaker less, we have time. Anyone? Dr. Vijaya, do you think that the...
I think there is one,
Oh, yeah.
Trupti.
Sorry.
Thank you, ma'am, for the excellent talk. My question is regarding what about if the patient has high lens fault? And do you recommend any cutoff to consider for the high lens fault, to consider lens extraction, particularly if we are planning TRAB also?
I think the Eagle study is not addressing that aspect,
Yes,
but if we are talking about the primary angle closure glaucoma in advanced stage that needs the trabeculectomy,
Yes, ma'am. Especially those who have a very narrow angle. So if
that
there
is
a lens
again
fault, because then
again.
their lens is clear. So then again that dilemma come whether to touch that lens or not.
Yeah, and high lens vault is one of the predictors for the possible complications following the trabeculectomy. There are situations where one has considered removal of the lens in such situations. It's not a general rule for the clear lens extraction for that.
Yeah, I think the lens vault is very high, and although the vision may be good, it's an indication to remove it because that's probably the main anatomical risk factor with a big lens vault. Yeah. But I think, it's very rare that there are very clear, huge lens vault and 6/6 vision and I don't think it's going to be, it's probably have some degree of cataract usually.
Thank you, sir.
Dr. Vijay, in India, what is the current recommendation in terms of clear lens extraction? Is there like a GSI guidelines?
Yeah, I think part of my talk reflects the JSI guidelines. I think we do consider the lens extraction in presence of the any lenticular changes. And as you correctly have mentioned that if the lens vault is very high and it is causing problem, that is the only exception we will consider for the lens extraction. Thank you.